All right, guys, it's 4:05. Why don't we go ahead and get started? Thank you so much for joining. This is Jacob Kirsch. Gonna be hosting you today for NASCI's Curious Cases webinar. This is the session for April of 2022. So let's start with the first basic question: is can you hear me? You can put it in the chat.
Yes.
Perfect. Perfect. Hey, Prachi, good to see you. Thanks for joining. All right, so
Great.
yeah, looking forward to it. So I prepared just a few cases that I saw recently that I thought were interesting to share, and some of the stuff that I learned about them as well while researching them for this presentation. But if anybody has cases, anybody wants to start, or I can start as well. I'll go ahead and start, I guess. Let me see. I'm gonna stop presenting this and share my screen so you can see my cases. All right, so we're gonna put this in play mode, and I believe that you guys can see my PowerPoint. Perfect, very good. So again, I have a few cases. The first one is this one. It's a patient presented with chest pain in the ER, younger patient, and they ordered a coronary CT angiography to rule out obstructive disease. Really, this was a low risk patient, no significant comorbidities. And this is this CTA. It's going to be scrolling probably a bit. I have it slow here so that it can project well on your screens. But is there anything there that catches your attention?
There's a left SVC.
Yep. Correct. So this, we see this here. We do see a right SVC as well. So there's a duplicated system. And this, let me stop right there. So when I was looking at this case clinically, because I was reading it, something caught my attention. And it just, for example, here, you see this structure here has higher attenuation than the left-sided SVC. And let's see if I can sell this to you guys. Seems like there's a little bit of blush of contrast into the left-sided SVC. So there's one there. And then here as well. And I'm gonna show you now, guys, a NPR. We have this is the left-sided SVC, and we have these structures here with, again, more contrast in them than the SVC and what looks like a blush of contrast. So as I was reading recons, it just caught my attention. But again, at first I was thinking, like, is that the coronary artery going into the SVC? Could that be an anomaly of termination of the coronary arteries and just fistulizing? And again, just because I've rarely seen, number one, you don't see left-sided SVCs that often. I mean, you do see them, but not every day. But I don't recall seeing that differential in contrast and contrast dumping into that SVC. But going back to the axials here, we can actually follow those structures. So here's the first one. And if I go cephalad, there, it's this actually the coronary vein just curving there and draining into the left-sided SVC. So these are all coronary veins draining into that left-sided SVC. So again, this is all appropriate. This is just the timing of the contrast makes the veins have a higher density than the SVC at this point. Again, it just kind of highlights where the coronaries are. Again, otherwise they would all go into the coronary sinus, which in essence, that's what they do here. It's just that it looks a little bit different when you have a persistent left-sided SVC. So it just kind of caught my attention. It was a little bit of a variant of normal anatomy. Again, left-sided SVCs still drain into the coronary sinus and by default the right-sided chambers, the right atrium. So there's no shunting associated with them. And again, just to kind of go over this, I think most of you have heard some of this in one of our cases in the past, but a left-sided SVC is the most common congenital venous anomaly in the chest. And a very small minority of cases can result in a right to left shunt depending where this SVC is terminating. It's seen in a small proportion of the normal population, about at least at the most 0.5%. And approximately of those, 5% of those will have, or in about 5% of those with congenital heart disease. It is seen in isolation in about 10% of the cases, and most of them are going to be like the one that we just reviewed, which has an accompanying right-sided SVC. So it's going to be a duplicated system, what we call a duplicated SVC. In 65% of the cases of the duplicated SVC, there will be absence of the brachiocephalic vein, meaning there's no communication between them up in the anterior higher mediastinum. They're going to be truly isolated systems, and usually the right SVC is smaller than the left. That's in the vast majority of cases. That has been my experience as well. What's interesting is that and this is a good example for in-service exams and board exams for those trainees to know what's the differential diagnosis of a structure to the left of the aortic arch. Again, usually to the left of the arch, there's only lung, but when we have an enhancing structure, our differential is pretty much contained within three different etiologies. One is a left-sided SVC, like the one that we saw. The other one is partial anomalous pulmonary venous return of the left upper lobe, and it could be a node that's enhancing, avidly enhancing lymph node. So that's usually the three differentials. Just to kind of, you see the arch. So again, that enhancing structure to the left of the arch would qualify for one of those three as part of your differential diagnosis.
Hey, it's Elliot Gozanski. Can I add one more to that list?
Of course, Elliot, please do.
It's a supreme left intercostal vein.
Correct. Yeah, we do see those when you're absolutely right. Those are usually tiny. I've never seen one aneurysmal or dilated, to be honest with you. But yes, you're absolutely right. We do see those, and they're just usually small. Have you seen one that may be confused with something else that it's larger?
Not that big, but I mean, when I'm telling the residents, you have to explain any vessel that's to the left of the aortic arch. That's one that I always include, because I think it's probably the most common of the group. But you're right; they're usually relatively thin.
You're absolutely right. Yeah, perfect. Thank you much, man. All right, so that was just a quick.
If you're completing the differential diagnosis, then there's just one more: levoatriocardinal veins, which are persistent channels between the pulmonary veins or left atrium and the systemic veins.
Correct. And yeah, we're that one we're really digging into the land of the unknown. Those are
right, exactly.
Yes.
But
I think we presented two cases in this seminar, in these webinars already. You're absolutely right.
that is correct. Yes.
All right, very good. Second case. This is a very interesting case. 67-year-old male. We saw him after he was admitted at an outside institution for heart failure and some VTAC. And when reviewing the chart, he had a past medical or surgical history of a resection of a papillary fibroelastoma. Papillary fibroelastoma, those are the small masses that occur in association with the heart valves, most commonly the aortic, but they can be in any of the four valves for sure, but the vast majority, again, in the aortic. And this patient, after that, required a pacer insertion and a VT ablation procedure. And again, he came from an outside institution, so we don't have a lot of history on it. And again, I kind of question what they talk about here with that past medical history. I'm wondering if somebody got it wrong when they did the intake on this patient. So this is the first chest X-ray. And any of the trainees on the call, anybody wants to say or give us a comment on what looks funky? Because it does look funky.
So, I mean, if this is Kuba speaking, one of the PGY5 residents.
Hey.
So, I mean, in terms of the pacemaker itself, so dual chamber device leads with are appropriately positioned and intact. I guess we've got some tenting of the left hemidiaphragm and enlargement of the cardiac silhouette. I'd say probably both right atrium and left atrium.
Correct. Yeah, everything you said is correct, and yes, you're right. I would say it's also, there's quite a prominence here of the upper curvature of the LV, almost like an upturn of the LV, so to speak. I will make one more comment. So you see this device, you call it a pacer. I think you can confidently call it an AICD. There's a battery
Yeah.
capacitor, so it's called, and you have the capacitors on the leads as well. So you can actually narrow it down a little bit further just based on that knowledge. But yes, your comments are appropriate. So let's see, I have a CT, and it's running a little bit faster, but any comments? I mean, you see the visor. It's going a little bit slower now in the axial plane.
So I mean, based off of the density, the attenuation, the fact that we're seeing the cavity of the left ventricle, that looks like a large mass, I guess is the first thing that would come to my mind.
Very good. Let me. So going up, I mean, and there you see the leads, and yes, definitely there's a differential there in the density, lower density, and there's what appears to be a large mass. What's very interesting here too is that it gives the impression, like, let's see, right about there, like the coronaries are being encased right there.
So I would be thinking of diffuse large B-cell lymphoma, and otherwise, I guess metastatic disease to the pericardium, I think, would be my two main differentials at this point.
All right, let's look at some short axis views. Oof is correct.
$906.97.
So any other thoughts here on this mass? And there's seems to be some central calcification as well, so there's calcifications associated with it.
I'm not entirely sure, to be honest.
No problem.
I guess calcifications in a lymphoma would be uncommon if it were not previously treated, which would, I guess, make me think diffuse large B-cell lymphoma would therefore be less likely.
Yep. So the one thing I and again, thank you for participating, and your comments are very good. The one thing that I would argue a little bit with the lymphoma is infiltrative, but it infiltrates through the fat around the heart, and it kind of adapts itself to the spaces, right? The path of least resistance. It rarely infiltrates into the myocardium like this, where it really takes over the myocardium. So that would be one comment. I don't know if Elliot Pratcher or anybody else on the line has had different experience with lymphoma really infiltrating and into the myocardial interstitium. The other comment is, and I think we have had a couple of cases here in these webinars as well. I'm going to give you some. I don't have the pictures here for this specific case. It was not imaged under MRI, but we've seen them before.
These are for abdominal aortic aneurysm.
If we can go on mute, please. Awesome. While we're participating, thank you guys. So the other thing is this will be extremely bright on your late enhancement sequences. And it will be somewhat encapsulated within the myocardium. Does that help you? Does that give you any ideas of what else this could be? Okay. All right.
I'm honestly not sure.
All right. No, that's perfect. We're all here to keep learning. Like I said, I learned something about this when I was reading about the case. So this is a cardiac fibroma. Fibromas are rare, but they're actually one of the most common pediatric tumors. They have a bimodal presentation, meaning another peak in presentation, and that be in middle-aged women, which doesn't fit this specific patient. According to autopsy studies, this is the second most common benign primary cardiac tumor in children's after rhabdomyoma. Again, usually these ones, as opposed to other ones, they tend to grow pretty large without having central necrosis or hemorrhagic changes. So they just look like a big piece of muscle that shouldn't be there. They almost always happen in the ventricles, usually in the left ventricle and towards the septum or left ventricular free wall. Like I said, usually very, very large, and they can have calcifications. That's a common presentation for fibromas. There was a very interesting study here that was published in JACC, and there's references there at the top right. They looked at a bunch of patients with cardiac masses, and they saw a total of 25 patients diagnosed with a cardiac fibroma out of the entire list of patients they had. The most common presenting symptoms in these patients were arrhythmias being number one, murmurs, and then an abnormal chest X-ray. So that tells you that as well they can go asymptomatic for a while. Clinically significant arrhythmias are the most common. They're more common in fibroma patients than in any other tumor group. And again, that's how this patient partially presented to this case. So this patient actually had to be treated. I remember heart failure of less than 30%. That big piece of muscle was probably not letting the LV contract appropriately, plus the risk of the VT and malignant arrhythmias. So this patient actually underwent heart transplantation. So this is the explanted heart in this patient. You can see the size of that big fibroma, taking most of the anterior wall of the left ventricle. So again, just a very, very dramatic presentation of this mass.
Sorry, I have a question for you quick. So when we were looking at the original images, you said that this mass was clearly infiltrating the myocardium. How could you tell based off of those CT images that it wasn't just a mass, I guess a pericardial mass resulting in mass effect? How did you know that it was within the myocardium itself based off of that CT?
I honestly will not be able to tell you that I know that for 100% certainty, but there is no fat plane. There is no plane between the myocardium and the mass. And
okay,
I think the other fact is also the epicenter of the mass, right? Like this mass is really centered on the myocardium, not on the pericardium going and infiltrating. You can see the thin pericardium kind of abutting it, but the epicenter is really the myocardium.
correct. So, and to be frank with you, is I think I've seen a good number of fibromas already that they all start to look a little bit similar, and you start once you see one, it kind of brings that memory of like, I think I've seen something that looks like this, and kind of puts it in the top of your differential. And that's when it's helpful just to continue to go over as many cases as possible, and always try to keep reviewing cases and learning.
Thank you.
No, thank you. And this is the third case. And again, this is just a quick show and tell. This was a great pickup. This is a patient that presented with abdominal pain. They did a CT of the abdomen and pelvis in the ER, and a very astute radiologist. And I'll start with the disclaimer that wasn't me. So kind of picked this up. So I have two images, one in the axial plane, and then I have a coronal reformat. Anybody wants to talk, make any comments, or do you know what we're looking at?
So I guess this is a LVAD, and I would be concerned that there's a thrombus within the, I guess the tubing anterior to the right ventricle.
Correct. So the inflow cannula, you're talking about this here?
Yes.
Okay. So again, when you see here on the coronal reconstruction, you do see this soft tissue layering within the inflow cannula. Again, that's coming into the left ventricle here. I should say this is actually the outflow cannula because it's prior to the device. The inflow cannula is the one entering into the ventricle. So this is going to be the distal part of that outflow cannula of the LVAD. So again, just a quick list. This is from paper and radiographics out of Mayo Clinic with the most common complications. And you can see it's the way thrombus formation is described is exactly the way we see it, and they're somewhat common. So slow attenuation mass adherent to the cannula or the inflow areas of the heart, then these are usually related to lower flow. From the same paper here, you can see there's a difference. The first generation of those pulsatile pumps were very susceptible to thrombi if there was any issue with the pumping capability of the device. The newer devices, those with continuous flow, can also cause thrombi because they have high velocities of blood through very narrow orifices, and again, they can generate shearing in some of the wall of those cannulas, can result in hemolysis and activation of the platelet cascade. The surfaces on the LVAD are biologically active, so again, they can produce local procoagulant, pro-inflammatory environment for this thrombus to occur. So again, on CT, like it's described, it's just low attenuation material within the left ventricle or parts of the device. And again, a reminder to look at all four corners of the images. Again, this was caught in a CT of the abdomen and pelvis. Patient had no symptoms related to this thrombus, but this could have definitely gotten worse and eventually be symptomatic. So it's a good thing that it was caught at this time.
Jacobo, may I contribute something?
Well, just because you're the president,
related to that case.
just because you're the president of the society. Otherwise, I don't know if I would allow you.
Okay. Yeah, I just want to say, you know, in the LVADs, a lot of times there is, you know, this rigid cannula, and then inside that cannula is actually a sheath that, you know, contains the blood. The blood is not contained by that outer rigid sheath, and that outer rigid sheath is actually porous, and sometimes you'll see air in the mediastinum because someone's had a surgery, and you'll also see foci of air existing between the inner sheath and the outer rigid sheath. The reason I point this out is you can get fluid that pools there, and when it's smooth for the entire run of the cannula, that's actually a normal finding, and it's not thrombus. So, you know, so I'm just telling this for the people on the line that you have to just be aware of that you can get this low density material circumferentially around the inner margin of that rigid sheath. Thrombus, you can be confident in calling a thrombus when you see irregularity to that. I have one case here that I can quickly show you a picture of a thrombus in the cannula. Let me see, would you like me to share the image with you?
100%. I'm trying to make you a presenter. So go ahead and set.
All screens, main screen. Hold on, applications. Okay, I'm going through my little thing here. Okay, here we go. Okay, there. Okay, so this is an example of a patient. So this is the outflow cannula, and you can see, I can zoom it up. So you can see how there's that irregularity there. That is, you really can confidently say that there's thrombus in this case. I have some other cases, maybe I'll dig it up before this is over. But you will actually see something smooth around the border, and that's not thrombus, because on other images, you'll see foci of air, that's air coming from post-surgical air in the mediastinum. So just for people to be aware of that. I have another case here of thrombus. Hold on one second. How do I, not sure how I, kind of feeling like older than I really am. How do I break the sharing? Okay, here we go. All right, now let me see if I can share again. Okay, application.
Let me know if I need to invite.
So here's another one. Okay, so this is another case where you can see how there's this like thick irregularity that you have, and this was a patient who was actually quite tight if you did an NPR. So this was a person with thrombus, but when you just have something smooth going all the way through the canal, it doesn't necessarily mean that it's thrombus, and it may just be a normal finding from this double layered, the double layered nature of this device. So that's all I wanted to just throw in there.
So since we have you presenting, do you have any other cases you want to share?
I don't. No, I don't have any others right now.
All right, perfect.
No.
All right. I see. We have a nice.
I can present it.
All right. Let's see. I'm gonna make Prachi the presenter. And all right, you should be able to show your screen.
Okay. So this is a 82-year-old person incidentally detected cardiac mass, since we're on the theme of cardiac masses. And let me show you what this looked like. So this is the 4-chamber cine imaging, and here is the mass. This is a still image showing you the mass, again centered on the interatrial septum. Here is T1 weighted imaging, T2 weighted imaging. And I can show you some additional images. I think that'll be really helpful. Here is perfusion imaging, showing practically no uptake of contrast. And this is a delayed enhanced imaging, where this was actually done with a 600 Ti delay, and you see this lesion really dark. So putting all these tissue characteristics in mind, what might this be? So here is the lesion, T2 very bright, and shows no enhancement. Any thoughts? Anyone wants to go for it?
Well, based off of the hint on your next page, a intracardiac bronchogenic cyst.
Oh my gosh, can we see? You guys can see that? All
Yeah.
right. Which I'm sharing. Okay, looks like I'm sharing the wrong screen. But anyway, yes, that's exactly what it turned out to be. This is actually. And the reason I wanted to show this is because this is exceedingly rare. But if you see on MR, I think the most important thing you can tell in this case is the cystic nature. So it's very homogeneous, T2 homogeneously bright and no enhancement. So in any other body part, I'm sure you would immediately think of a cyst. And that's exactly what it is. And intracardiac bronchogenic cysts just tend to occur in the interatrial septum. So I've seen this in the books, but this was the first time I actually encountered it. We're not really going to do anything about this. The idea is not to resect it or anything. Most of the published cases, people have resected it, but I think this is such a clear diagnosis with an 82-year-old incidentally detected lesion. So the idea is to just follow this up. So I just thought this was so exceedingly rare that I wanted to really share this. And since we were on the topics of fibromas, Jacobo showed a beautiful case, but this is an RV fibroma. And this is, again, exactly what he was mentioning. When you see one of these cases, I think they have that look to them. These are almost like they are very exophytically growing lesions. They have some endoluminal component, but they really tend to grow outwards. And this is the MR picture. This one showed peripheral enhancement. And again, very, very clear peripheral enhancement and had a central non-enhancing center. But they are typically very brightly enhancing structures. So again, this was actually a young kid. He was like a 2 or 3 year old, came in with arrhythmias, fibroma, and exactly as Jacobo said, you can see calcifications. And the differentiation from a rhabdomyoma in this kind of an age group is that fibromas occur typically in a slightly older age group. They can show calcifications unlike rhabdomyomas. They tend to be solitary and really large, whereas rhabdomyomas typically are more multiple. But since we saw this on CT, I just wanted to show you the MR correlate on this. Excellent.
That's awesome.
That's it for me.
Awesome. Thank you. Really great cases, Rachi. Thank you so much. And now, guys, now you saw an RV fibroma as well, which are not very common at all. So great. And that was some really quick work there after you saw the other one. So you put this one together. Impressed. I'm very impressed.
No, this is the lecture I had. I was updating my lecture today. So
That's awesome.
I saw this.
Perfect timing.
Yep.
All right. Anybody else on the call who wants to share some cases?
I have some cases.
All right.
It's Carol.
Hey, Carol, let me make you presenter. Thanks so much for, I know you had a meeting. How did that go?
That was fine.
Awesome.
Thank
Perfect.
you.
Thanks for joining.
Thank you for inviting me. Okay, so share. Okay, now can you see my screen?
Yes, if you want to put it in presentation mode, all right, and then you want to swap your,
Okay, how do I swap that? Options? No.
top right, swipe displays, top left, I'm sorry, top left, swap displays, the one to the left of that. That one.
Okay.
No, swap
This
display.
went totally black.
There you
My
go.
screen just went completely black. Can you?
We're
Yeah,
seeing,
but my screen went. Oh.
oh,
Okay. What are you seeing now? Oh, you're not seeing my presentation though.
I see your desktop.
I'm just gonna take it off. Okay, I'm just gonna take it off. It still went to the wrong one, didn't it?
Yeah, you just hit on the top left, swap displays. Top left, there's a option. There you go.
Got it. All right.
There you go. All right, perfect. Thank you.
Okay, I'm getting old. Sorry. Okay, so also it went to the wrong slide. So sorry, I'm gonna have to go back and okay, we got it now. So I also have a couple of cardiac masses. So this was a 19-year-old guy who came from Somalia, immigrated 6 years before presenting. This is an old case, so the MR imaging is not going to be the best quality. He'd had increasing shortness of breath for a year and swelling over the dorsal surface of his left wrist with some ulcerative nodules on his hand. He had no fever, cough, weight loss, or night sweats. The only thing on examination was that he had these lesions on his hand and finger, and he had features of right heart failure on clinical exam. And so his initial investigations, ECG showed some right atrial enlargement, SCT wave abnormalities. His echoes showed severe right and left ventricular dysfunction, right atrial dilatation, pericardial thickening, and features of constriction, with a right atrial free wall mass that measured about 5 centimeters. Biopsy of the hand lesion showed synovial hyperplasia with necrotizing granulomatous inflammation, but nothing grew out of that, specifically no evidence of TB. This is his CT at presentation, old CT, 5 millimeter thick images. You can see he has some large, slightly enlarged lymph nodes in the mediastinum. He's only 19, so some residual thymic tissue there. And as we come down, we can see this mass either in the wall of the atrium, in the atrium, or pushing on the atrium. It's pretty hard to tell. And you can see that the pericardium is thickened here. And the ventricles have, especially the left ventricle, has this kind of elongated tubular appearance, which is a sign of constriction on CT. And you can also appreciate that IVC is, 4 times the size of the descending aorta. So also some evidence there of probable constriction. So moving on, he had, oh, I also want to show this is an unenhanced CT that was done prior to the enhanced CT. So there's no calcification in that mass. And these are images from an MR that was done. So T1 weighted coronal imaging acquisition, T2, and then T2 fat sat. So you can see it's pretty ISO intense, a bit inhomogeneous on T1 weighted imaging, hyper intense, but inhomogeneous again on T2 and T2 fat sat, slightly more hyper intense, especially along the wall there. And this is a trophy image, so definitely not fluid intensity. I think, okay, so this is, these are the cine images, and you can see the mass in, or difficult to know whether it's in the atrium and the pericardium or along the wall inside the atrium. This is a short axis oblique, and you can see that it's the IVC is significantly distended. And on the SAO cine, you can see that there is that pericardial bounce, and there's pericardial thickening in this region here, if you can see my arrow. This is the dynamic perfusion run. Not really any enhancement. And these are 5 minutes post-injection. I think at the time we didn't have LGE, so this was a very old case, but there was no enhancement. So the patient went on, and this is just a show and tell case. He had surgery, had a pericardiectomy, and a right atrial mass resection. There were dense adhesions between the pericardium and the epicardium, and dissection along the AV groove kind of got into this thick yellowish material that oozed out from the right atrial wall. And the specimen was sent to pathology. And pathology, this is the specimen, and it was a necrotizing granulomatous inflammatory mass with giant cells and fibrinous pericarditis, and this was due to a tuberculous infection. Now, somehow my slides were a little bit out of order, and my discussion slide is here. So hematogenious spread of TB may manifest in any organ. Cardiac involvement is rare. There are 4 stages of infection of the pericardium that have been proposed: the dry, effusive, absorptive, and constrictive. And then the clinical symptoms are non-specific. They can have the heavy cough, or typical cough of TB with expectoration is usually absent, and there's no specific ECG changes. So this was a rare case of tuberculous pericarditis. And I think in retrospect, just looking at the images, we're probably looking at an abscess, right? It's not really fluid on the T2 weighted images, but it's high intensity. It doesn't look like fluid on the trophies, and then there's no enhancement at all on the post-injection. And so it didn't really look like a thrombus, which would have been dark on many of the sequences. But I think what you're seeing here is probably the pus that isn't enhancing, and then the wall looks like it's probably enhancing. Any comments, questions about this?
No, that's, I mean, I don't see this often. Of course, the ones that I've seen, they look a lot angrier than this. To call them tuberculous pericarditis, usually like very complex multilocular, they just look like really, really aggressive. This is a great case.
Thank you. I have another case, another cardiac mass. I haven't had a chance to read around this a lot, but this also is a cool case that is a 42-year-old woman who presented just a long time ago, and maybe Prachi was there when this case presented. Patient had a right ventricular mass on echo, and she had initially a CT of the chest. I'm showing a cardiac CT here that was done later on, just because it's an old case and the CT was not that pretty. And you can see much better with this cardiac CT. There's a large mass that looks like it's contained within the pericardium. You can see the right coronary artery is coursing through the mass. And the mass is pretty vascular. You can see pooling of contrast within it. It's significantly compressing the SVC, as well as the right atrium and the AV groove. So differential of lesions in the AV groove. Does anyone want to provide a differential?
Any brave takers?
If not, I can. Well,
I can throw in
three. Sure.
We could talk. I think Kuba mentioned lymphoma. I think lymphoma can do whatever it wants, so I would throw that in there. Of course, angiosarcoma is one of the known entities that we know likes to go in the AV grooves. And of course, when you're talking about cardiac masses, you want to bring the idea of metastatic disease, and when there's calcifications within it, could be that the primary is either an osseous tumor or a cartilage tumor, some sort of osteosarcoma or sarcoma. There is such a thing as a primary osteosarcomas of the heart, but that doesn't look like a good position for those. And it's too big. Those, I mean, metastatic sarcoma probably would have already killed the patient. So I like angiosarc, I like lymphoma as good options here.
Yeah, that sounds really good. Now, at the time, we had a really, really brave radiologist, and if Prachi's there, she might remember Fred.
Cannula, I don't remember the case, but the brave radiologist definitely brought back memories.
So this was way back in 2003, and so he biopsied this lesion. He did FNAs and was going to do some cores, but he noticed, like, at the beginning of the biopsy, he did a scan and could see there's tiny, tiny pericardial effusion. And then, after the FNAs, the patient had a little bit of chest pain, and he noticed that there was a small pericardial effusion that looked a little bit high density. So he called it quits at this point. Luckily, the patient didn't have any post-biopsy more adverse events, did remain stable and went home. And he went for a mediastinoscopy and had the final diagnosis provided from this mediastinoscopy. So just this patient we've been following since 2003. So obviously it was not an angiosarcoma. And so you can see on T1 weighted imaging, it's iso-intense to myocardium, very hyper-intense on T2 weighted imaging with FAT-SAT. And these are some axial cines, short axis cines. Very homogeneous on these pre-contrast images, and then post-contrast you can see significant enhancement. So we do our usually the SAOs we do before contrast, and then we do often the 4-chamber is done without contrast, and then we inject, and we keep on doing the cines. So this 3-chamber was actually done after the cines. And
I guess if you showed me the initial images again, like Dr. Kirsch was saying, extremely vascular. I guess parts of it kind of to me looked like if you took a hemangioma in the liver and you just made it even bigger and angrier. It kind of looked like it had that, I don't know, like that peripheral nodular enhancement, but maybe more heterogeneous than that. But I mean, I guess I was also thinking some sort of vascular tumor.
Yeah, and that makes a lot of sense. This is the dynamic perfusion, this is the post-contrast 5, and then this is the LGE. And so what this actually is a cystic lymphangioma. So it is a vascular lesion, and is benign, and it's very rare. And we've been following it since 2003, as I said, and it's slowly increasing in size. The patient is still asymptomatic, and it was deemed to be unresectable back in 2003, so still following. And she's 58 now.
And that was next on my differential, but you didn't let me finish.
Oh, I didn't. I'm sorry.
No, wow, that's a great case.
Yeah, it's pretty cool. So we're probably out of time. Oh no, I have one more case. If
go for it, please.
Yeah, quick question about this one. So this was a lymphangioma, but the amount of enhancement is really out of proportion to what we would see with that. So do you think there's a component of like a more other vascular or hemangiomatous component, as was alluded to previously?
Yeah, that's quite possible. I mean, we have pathology, but it's just from a small tissue, a mediastinoscopy. So it's quite possible they only have a sample of part of the lesion. So yes, definitely could be a complex lesion with more hemangioma within it.
Before the biopsy, would you guys have considered a germ cell tumor?
It seemed to be all contained within the pericardium. I don't know. I've never seen an intrapericardial germ cell tumor.
It was just the first thing that came to my mind when I saw it.
Yeah. And it was all like very homogeneous, no calcification on the CT.
Yeah, I suppose I was thinking something more aggressive than a teratoma.
Yeah, we were thinking of an angiosarcoma at the time. Yeah. Okay, so the next one is also an older case with an MR that was done at another institution. 57-year-old man who presented to our emergency department with ventricular tachycardia. This is not a cardiac mass, so Had a 1-month history of fatigue and progressive shortness of breath with frequent palpitations and signs of congestive heart failure, but he'd been previously healthy, a recreational runner, and there was no family history of sudden cardiac death or early coronary artery disease. His initial investigations showed an elevation in troponins with no peripheral eosinophilia, normal ACE. Post-cardioversion, his ECG showed sinus rhythm with left axis deviation, anterior T-wave inversion, and evidence of an intraventricular conduction delay. He had an echo that revealed significantly reduced, mildly or moderately reduced LV ejection fraction. LV was hypokinetic. The right ventricle was moderately dilated with mildly reduced systolic function, and he had a normal coronary angiogram. So he went on to MRI, and these are T2, these are stir images showing increased signal along the endocardium of both ventricles and the right atrium. Probably increased signal within the cavity of the ventricles that's likely related to slow flow. Then the cine imaging revealed reduced ejection fraction to 33% for both ventricles. The right ventricle was significantly dilated, and the LV was normal in size. There's global hypokinesis. They missed the boat on the LVAD, so I'm using the phase-sensitive inversion recovery images to show you the extensive subendocardial enhancement in both ventricles, but significant right ventricular subendocardial enhancement and enhancement along the trabecular moderator band and the papillary muscles. So anyone with a differential?
This was a gradual onset of symptoms, is that correct?
About 1 month.
I'm not really sure, but I guess it's pretty extensive, so I'd be thinking of some sort of infiltrative process. You said subendocardial enhancement throughout, so I guess it's not, we're not getting like mid-myocardial like we'd expect with a myocarditis. I don't know if like amyloid or sarcoid could possibly look like this.
Sarcoid is a good possibility. There was an elevation in the troponins. So is there, however, the eosinophil count was normal, but just as a differential, I guess, would you include another kind, a specific type of myocarditis?
I guess you already said that eosinophils are normal, correct?
Right, but there's a couple of kinds of myocarditis that can, there's one other kind of myocarditis aside from eosinophilic, which I was alluding to, that can have this extensive enhancement.
I'm not sure, to be honest.
Okay, so giant cell myocarditis is the other kind of myocarditis that can lead to, it's often involves multiple layers and it's extensive enhancement of the myocardium, but it can be limited to the subendocardium. You mentioned sarcoid, which is a possibility, and then there's also arrhythmogenic ventricular cardiomyopathy, which the clinical picture here doesn't really go with it because of the elevated troponins, but you can have some left ventricular involvement as well as right ventricular involvement by ARVC. And so this patient, unfortunately, well, fortunately, had a cardiac transplant, and this is the patient's explanted heart. So what do you think might have been the cause if you look at these guys here on the pathology specimen?
Look like giant cells.
Yes, so this was a case of giant cell myocarditis, which typically has a fulminant course that either results in death or cardiac transplantation within several months. So the explanted heart shows significant fatty infiltration of the ventricles from the outer walls in, but also at pathology there were all these giant cells noted within the myocardium. So I think I'm done.
Those were great cases.
Thank you very much.
Thank you,
You're
guys.
welcome.
All right, it's just a minute past 5. Any comments and anything else, guys? I mean, I want to thank everybody for showing up. Everybody that prepared and presented cases. That's the goal of this meeting, for everybody to share. So, thank you for a great meeting. Hope to see you guys on our next NASCI cases again, the first Monday of May. Have a fantastic evening, guys. Thank you so much. Take care.
Thank you.